welcome everyone that's joining us in the room today. It's my pleasure to welcome you to all today to the Living Good Lives webinar. We're here today to focus on supporting adults with learning disabilities and or autistic adults in communities through best practice commissioning. This is the first in a series of 3 webinars that we've developed in partnership with NHS England, Care Quality Commission, Skills for Care and NICE. The focus of today's webinar will be on supporting adults with learning disabilities and or autistic adults to live good lives in their community through best practice commissioning. Next slide, please. The NHS England Homes Not Hospitals campaign has a focus on best practice commissioning and campaigning with and on behalf of autistic adults and people with learning disabilities who are in assessment and treatment units due to the lack of support for them to live in the community. Our campaign brings together partners from across the sector to work in partnership to promote preventative approaches in terms of commissioning, human rights-based practice, the role of social work and legal literacy, and thinking about reducing the risk of situations from reaching the point of hospital admission. Where the person is already subject to this type of care and treatment regime, they need to be supported to leave as quickly as possible to a place that they want to live with the right support in place for them. Today, we're going to be focusing on sharing information with you about the key issues that face commissioners and thinking about what that means from a lived experience perspective. The current priorities for commissioning, including again from that lived experience perspective and the perspective of the organisations that will be sharing the information as part of the webinar today. We'll also be looking at how to access resources, training, best practice models and examples to support commissioners to plan preventative local services for adults with learning disabilities and autistic adults. We'll also be sharing with you the NHS England Homes Not Hospitals best practice commissioning resources that contain a set of absolutes and principles and recommendations for commissioners at a local, regional and systems level. So in terms of housekeeping, all attendees today will be on mute throughout this webinar. If you do want to get in touch, that's great, and we really hope that you do, to ask questions or to comment. Please use the chat box, which should be at the bottom of your screen, or it may be displayed differently, but it should say chat. We really want to hear your questions as well throughout the webinar, and we've got a slot for the last half hour where we're coming to your questions. The resources that you'll hear referenced in the webinar today will be shared with you along with the presentation as well. And there'll be a post-evaluation form that will come out after today's event. We're really encouraging anyone that's on Twitter to post messages during the session. And if you do want to tweet during the webinar, then please use the hashtag #SWListening. So without further ado, I'll introduce our guest today, and I'm going to start by bringing in Nicola. Nicola, if you would like to come in, please, and introduce yourself.
Hello, everybody. I'm Nicola. I'm Georgie's mum. I've been a parent carer now for over 25 years. I'm also an expert by experience for CETRs. I've been an independent advocate supporting mainly young adults with autism and LD in the community. And I'm also involved in the Independent Strategic Oversight Board for NHS Improvement, looking at the task force for Tier 4 CAMS.
That's great. Thank you very much, Nicola. Debbie, if we can come to you next, please.
Good afternoon, I'm Debbie Ivanova. I'm the Deputy Chief Inspector for People with a Learning Disability and Autistic People at CQC, and great to be with you today.
Many thanks, Debbie. Poppy, can we come to you next, please?
Hi everyone, I'm Poppy Green. I'm a Strategic Commissioner for the London Borough of Camden, and I'm going to talk today about the recommissioning we did for our supported living contracts.
Great, thanks Poppy. Candy, if we can come to you next, please.
Yeah, my name is Candy Worth. I'm the Senior Commissioner for Mental Health and Dementia at Somerset County Council, and I recently took a BCE Level 5 qualification in commissioning. So I'll be talking a little bit about that and some resources you can use to sort of improve and further your practice.
Thanks, Candy. That's great. And Di, if we can come to you next, please.
Yeah, sure. Hello, everyone. I'm Di Domenico. I'm the commissioning lead from the Learning Disability and Autism Programme. I've been in the programme since the beginning. I'm a commissioner by background, and I was part of the team that wrote Building the Right to Support. Really pleased to be here.
That's great. Thank you very much, everyone, for introducing yourselves. And we're going to be hearing from each of our panel members as we go through the webinar today. Okay, so first of all, I'm really looking forward to introducing our first guest today. That's Nicola Bartes, who's going to be talking about the journey that her son George and herself have been through, particularly in terms of lived experience perspective, and really thinking about the difference that commissioning has made in this situation. So over to you, Nicola.
Thank you very much, Liz. I'm going to move very quickly through the first few slides, and hopefully they'll help explain how we got to the situation that we found ourselves in later on. As this was pre-transforming care, it might be worth reflecting on what, if anything, has changed since then. As you can see, pub lunches were high on George's list of things that he likes to do more than anything. George had a mostly happy childhood. He was the second of 4 children. He always loved being part of the gang. He was always in the middle of everything. We did lots of activities together as a family, from local days out to family holidays in Cornwall. And it's worth remembering that this was my baseline for George later on. This is what I had in mind when I went to all of those best interest meetings and we were planning for his future. But as he got bigger and more challenging, we were referred to CAMHS and he was prescribed quetiapine, the antipsychotic, when he was about 11 or 12 to help manage his behaviours. Next slide, please. So as he went through teenage years, he experienced a number of life-changing events. He had 2 major operations on his legs, which involved a lot of pain management, physio and OT, learning to walk again twice, which for someone with autism was very difficult. He became very frustrated at times and developed some very challenging behaviours. We also went through family breakdown. As he went into year 9 at school, it was that year that all of his peers, all of the boys in his year group at school disappeared. As far as he was concerned, they all went off to residential places. Then when he was 15, he had his first epileptic seizure, which was quite a shock. And that was another change that he had to adapt to. And each of those things on their own, he might have been able to cope with support, but the cumulative effect resulted in him eventually becoming catatonic. Next slide, please. And it wasn't an overnight event. It took 6 to 12 months for him to gradually shut down. So I contacted social services and one of the team leaders did a home visit. And I can very distinctly remember him looking at me and saying, "But you're a coper." I had been approaching school, respite, his paediatrician, his GP, everyone we'd had contact with to support my request for CAMHS to review his medication. But CAMHS had discharged him from the service and said we could go back on the waiting list, which at the time was 18 months. And like a lot of families that were going into crisis, when I asked for help, it wasn't there. He became even more unwell. I went into emergency respite, and from there he was admitted to our local general children's ward, and from there to an adult LD mental health ward when he was 16. So he was admitted as an emergency, and when all I wanted was a medication review so he could stay at home and be supported. He was diagnosed with catatonia and stayed there on the mental health ward for 16 months. He had been ready for discharge after 4 months, but the rest of that time was taken up by legal arguments about who would fund his placement, because by then I had moved areas. And this was 2010, 2011, and there were no CETRs back then, just the CPA. And I'm sure a CETR would probably have put pressure on the authorities to decide who would be doing the funding. Next slide, please. George was discharged to a residential special school near me. I'd moved up to Cheshire by then and managed to attend school with quite a lot of support. He then stayed with the same provider, moved on to their adult services. went to live in a residential house with 2 other young men from the same school. There were then a succession of staff changes, and what had started out being very promising started to deteriorate. The service was failing to meet his needs, but they were not open, didn't ask for any support. So Georgie's behaviour started to escalate, and the environment became more and more restrictive. My access to George was also being restricted. I raised a safeguarding because I was so concerned about the level of care. His seizures were increasing in frequency and intensity, so his medication was increased, and then he was put on an antidepressant as well because he was spending so much time asleep in his room. I had already decided that this was not the place for him, and using my deputyship for finance, I found him social housing tenancy, and with social work help, we also found a new provider so that he could move out there into a place of his own. Unfortunately, the transition wasn't good. The old provider being less than honest about the issues that they were facing. And the first few weeks in his own home were actually great. It seemed to be working really well. But then there were 3 or 4 incidents of challenging behaviour in 1 week, and the staff said that they were not aware of his challenging behaviour. And the provider's area manager called the psychiatrist to do a mental health act assessment. They didn't review his PBS plan, and they didn't ask the community LD team for support. There was no red light CTR or a leap. The house manager insisted on a section and wouldn't listen to any suggestions that would have kept George in his own home. The provider then physically walked out of the house, leaving myself and the AMP with George. Next slide, please. So George was admitted under a section 2, which was then transmitted into a section 3. It was an extremely restrictive environment, quite a shock to our systems, and he was very quickly started on an antipsychotic to help him cope with the ward. Restraint and seclusion became a regular feature. About 4 weeks into his admission, he started to become physically unwell and was admitted to the local general hospital with jaundice. He was diagnosed with gallstones and had emergency treatment. Most people know how painful gallstones can be. So with hindsight, a lot of those behaviours and the escalation and the increase in seizures as well were probably caused by pain. So basically he was sectioned because he had gallstones. By now he was in such a restrictive, traumatic environment that the incidents were still there or worse, and it was just that the pain he was communicating was mental and emotional rather than physical. He had a couple of CTRs while he was an inpatient, and the recommendations were focusing on finding a new provider and getting him back to his own home because the tenancy was continuing at that point. Unfortunately, the clinical staff decided that his challenging behaviour was just George being George and would be ongoing, and they decided that he would need 5-to-1 support because of the use of restraint and seclusion. The clinical team approached a lot of providers who did those assessment visits and listened to the staff opinions and said no, they couldn't meet his needs. I have court-appointed deputyship for health and welfare, and I was insisting that he should return home with a new care provider. And the key to unblocking this stalemate, which lasted for about 10 months, I think it was action taken by the CCG commissioners. They attended the best interest meetings on the ward, and they listened to me, sometimes in the meeting and sometimes in those brief conversations that you have in the car park on the way in or out. And they listened to my reasons for believing that he could return to his own home with the right support. And if I take you back to one of the first slides, that was my baseline of knowing what works for him. So they arranged a meeting with myself, the commissioners, and a new provider that they had proposed. The new provider was reassured that they would have support from community teams and from the commissioners should his support need to change. The commissioners also reassured the extremely risk-averse clinical team by introducing a risk management tool which was basically a spreadsheet with the risks, mitigations, and who would be responsible for any actions. All of the stakeholders were asked to sign up to this, and it worked. And I was also reassured because by including me in the process, after the bad experience I'd had with the last provider, I had a chance to learn about the new provider and all their core values. So after 18 months in this second admission, George was discharged with 3-to-1 support, which has been under regular review, but back to his own home in the community. Next slide, please. So George moved back into his own home 3 years ago now. His new provider, Sugarman Healthcare, have weathered the storm and worked closely with George and with me. He still has his moments, and he probably always will, but they're managed quite differently from when he was on the ward. And he gets on really well with his support. He was discharged from the ATU with a need for restraint when he was in distress. So all of the team are MAPA trained, but the need for this has reduced significantly over time. LD nurses from the community LD team visited regularly for the first few months, and his CPA ended after 18 months rather than 12 because he had an increase in incidents around the first anniversary of his discharge. But there is no more seclusion, and when there is an incident, he goes around to check on everyone to make sure they're okay and they're still friends. They took him up in bed at night. I can see how he looks at them. And there's a big emphasis on building relationships and enabling him to have his best life. Staff have been quite creative in getting him out and about. He has waking night staff, so when he turns night and day around, which he does frequently, and in the summer heat wave, they took him out to see the sunrise on New Brighton Beach. Next slide, please. And there, picture paints 1,000 words. And this is the George that I knew was in there. This is his new baseline. And this is what living a good life looks like. Thank you. Back to you, Liz.
Thank you so much for sharing George's journey, Nicola. That was incredibly powerful. And I just want to kind of pick up on some of the key messages that you've shared there, which I think are important when we go into the presentations that we're going to hear throughout the webinar and that people might have questions about. So the value and importance, getting the right support at the right time has had for George in the end, but that would have made a difference during his journey. Cannot be underestimated there. That reference to you being a coper, that's something I know I've heard referenced in my career as a social worker, and I'm sure is still something that's bound about, but actually the dangers of labelling someone in that way when they're struggling. Legal arrangements and arguments about funding and our understanding about that, but actually the value that the Commissioner brought in the situation to unlocking, as you described it there, unblocking and unlocking things, and actually that really, really important focus on the reduction in restrictions and isolation through building relationships and through understanding that George's behaviour was about communication as well, and helping other people to understand more about that to move the situation forward. So thank you very much for sharing that, Nicola. Incredibly powerful and wonderful to see the images of George there in the situation that he's in now. So thank you, and we'll come back to you for questions later on. Thanks. Now it's over to Debbie, who's going to talk more about the work that's been happening at the Care Quality Commission, and particularly in relation to building the right support and thinking about that agenda as well. So over to you, Debbie.
Thank you. Yes, I want to talk to you about some of our findings so that we can help you too to think about things that are important to support people to lead those best lives. This first slide here is just a reminder of who we are and why. We always put this up because I think it's really important to remember that we are both about making sure that services provide safe, effective, compassionate, high quality care, but also about encouraging services to improve. So if we move on to the next slide. I want to talk to you a bit about our Out of Sight Who Cares report. And if you take anything away from what I say today, please go and read Out of Sight Who Cares, and also read our Right Support, Right Care, Right Culture, which are the two main documents I'm going to talk to you a bit about. So what did we find? Well, we found that too much money was being spent on supporting people in hospital. money which would be better spent on providing individual person-centred care in the community. We found a real over-reliance on restrictive practice, used much more than as a last resort, and very often demonstrated a failure of care rather than being the right response at the right time for people. It wasn't always clear how well commissioners monitored how people's needs were being met, and the value of the money that was being spent. The amount of money that was being spent and the amount of monitoring that went into some of those placements was always of concern to us. And we found that frequently people's needs were not being met, or they were being cared for by staff who were not trained to meet those needs. People weren't receiving the assessment and often not the treatment, and I'm using that word carefully because we're talking about people who were in assessment and treatment centres, that they were admitted for, and they were becoming absolutely stuck in services. This then leads to potential breaches, I think, of people's human rights. And often this wasn't being picked up and wasn't being addressed either by the staff or by commissioners for people in those services. Some providers told us that replicating the person's care in the community would be more expensive. However, in most cases, we found that wasn't the case. Community care packages were not more expensive, and if funded correctly, these could provide people with really good person-centred care tailored to their needs, with their own staff team and closer access to their home and the community, a reduction in restrictive practice, an increase in the quality of life, and all that for less money. And often the level of support does reduce as people are in those placements that meet their need. However, and this is very much shown by the story of George we've just heard, there's just not enough community provision. It needs that whole package of support to make this work well. Really good early intervention, really good prevention, crisis intervention, and the places where people can choose and the places where people can lead their lives that they choose. If we move on to the next slide, I'll just very briefly give you a few of the recommendations. So these ones were about the responsibility for and expertise in commissioning, and we feel that commissioning is absolutely central to getting this right. So there needs to be that responsibility, both nationally and in each local area, for commissioning, and making sure that people are trained and that they know to monitor and visit those services. Not to look at what does it say in the care plan, what does it say in the positive behaviour support plan, but what does that actually mean to the delivery of care for individual people? If we move on to the next slide, then there was a series of recommendations which were focused around people's human rights and embedding those in the commissioning and delivery of care. Everyone involved needs to understand what this means in practice. I think sometimes we get a bit frightened by things like human rights and we think, oh, what does that mean? What does that actually mean for how care is delivered? But actually it's the foundation of great care. So if we get staff trained in human rights and there are real checks on making sure that reasonable adjustments are being made for each person who is in services. I think we also want to think about discharge as the expectation that someone will leave and return to their life. And that needs to be in people's plans right from the beginning when they're admitted to hospital. You know, I think it's really helpful if you think about what does that person need now? What do we expect to happen with an agreed time frame, and how do we expect that to mean the person can move back to their home? So not this handing on of people, but actually it is a movement between if you need that care, into a specialist facility to provide it, and you go back to your home again. So this is about commissioning a service where people have the right skills to provide the right care and access to the right support in the community. One of the things I wanted to ask people is, do you know when you're looking at placing in a service what that service says it will provide? What is the specialism of the service that you're looking at? Have you looked at their statement of purpose? And this is so important at the moment because in the last couple of weeks, 2 services have come to my attention. One's a hospital and one's a care home. Both have taken people from services that have been closed, and neither should have, because neither of them are actually services for people with a learning disability. Placements were made without looking at what the service was offering, and the staff in the service did not have the skills in providing the care that they should have done. So they were not able to look after people well, and people are now in another placement that isn't meeting their needs. So if we move on to the next slide, I want to talk a little bit about right support, right care, right culture. Because if you get this document and you look at it and you think about it when you're placing, then that's going to really help to get the right kind of services. So you know this policy, know it well, use it, both when you're planning and when you're commissioning services. This is much more than guidance. This applies across all of the services that we work, including supported living. So, is it the right model of care, and do settings maximise people's choice, independence, control? What might tell you that the service does that well? What's the ambition for people's lives in that service? How skilled are the staff at enabling and promoting rather than containing and restricting? What's the quality of the relationships? Do you see trust and respect in those relationships? Right care. Care's person-centred, promotes dignity, privacy and human rights. How well does the care plan reflect what's important to the person as well as what's important for the person? Is the use of restrictive practice reducing? Are you monitoring that? How is your one-to-one staffing being used? The right culture. Are the ethos, values, attitudes and behaviours of leaders and care staff right? What's the language they use when they're talking to each other, about people, with people? How do they write about people? What happens when people do speak up, whether that be a staff, a family member, an advocate or the person themselves? How does the service change as a result of what people say needs to happen? If we move on to the next slide, CQC are very clear that we will only register services that meet this guidance. So there needs to be a clear need for it, and it's been agreed by commissioners. The size, setting and design of the service meets people's expectations and aligns with current best practice. People have access to the community. That means we won't register campus and congregate settings. And the model of care is in line with current best practice. Now, this includes supported living, and I really wanted to take this opportunity to say to you as commissioners, beware here. When you're commissioning, placing or reviewing someone in supported living services, you may be the only person who knows about that location. The way that services in supported living are registered means that we register the regulated activity, which is the provision of personal care. That means, firstly, that people who do not require support with personal care, which is very narrowly defined as bodily functions, will not fall under registration. So somebody coming out of hospital with very complex needs, who perhaps needs real support with their communication and support with distress, may not come under regulation at all. And then once we've registered an agency, they're delivering that care in people's own homes. Where that care is delivered, we may not necessarily know. And there are some providers who are purchasing entirely inappropriate settings and delivering care in those settings. You are the gatekeepers to ensuring that people get the service they actually need. So I just want to finish very briefly showing you this last slide, which is the expectations that we have been told very much by people. This is what they expect, this is what they want, and this is what our regulation and our work at the moment to try to increase the provision that's out there is focused on. Thank you.
Thanks very much, Debbie. That's really great to hear about all the good work that's happening in terms of Care Qualities Commission focus around best practice commissioning and all the sorts of things that we need to be thinking about and having in mind. A couple of things I'd like to pick up on were about the focus on really good prevention and the right community-based support. And that focus all of the time on people's human rights as the starting point when we're exploring what care and support and good lives might look like. Really helpful. Thank you very much. And if you've got any questions for Debbie or Nicola, please do put them in the chat and we'll come to those later in the webinar. Next, we're going to hear from Poppy Green, Strategic Commissioner with the London Borough of Camden. The information that Poppy's going to be sharing is reflected on our BASWA England's Best Practice Commissioning Guide for Homes Not Hospitals. And again, there's some key messages about the approach that's being used in Camden that Poppy's going to be sharing with us now. Many thanks. Over to you, Poppy.
Thank you. Thanks. So I'm here to talk about how we in Camden have used commissioning to enable adults with learning disabilities to live good lives in their community. And the example I'm going to talk about is the recommissioning of supported living, which we did via strengths-based co-produced approach. So just to give you a bit of a background then around our supported living contracts. So we had contracts from 2014 where we commissioned 3 providers to deliver supported living in Camden. It was a needs-based contract, which ranged from low to high needs. We had providers delivering services in various places across Camden based on the needs contract. The contracts are pretty standard, no real innovation, no real serious social value commitments, and so forth. So quite a standard contract. So in 2018, we embarked on a 2-year project to remodel and retender these contracts. And we did this by a competitive dialogue approach, which I will talk about in more detail in the next few slides, but it's essentially a procurement approach that allowed us to really co-produce the service. And then just along here on the bottom, I just set out a bit of a high level summary of kind of the timescales and the milestones through the project. So it was quite a big piece of work. Next slide, please. So just to give you an overview around the engagement we did. So we engaged with approximately 155 people. And I've kind of outlined the different people we engage with and how. So we gave ourselves a good 6 months to engage, and we made sure we got a good selection of stakeholders. So where we had people with learning disabilities, we made sure we engaged with people of various ages, people who were in services, people who weren't in services, different ethnicity, different needs, ranging from low to higher needs, engaged with family carers, providers, professionals, some of the market engagement, benchmarking. And we tried to talk to as many people as we could, and we did it in as many different ways as we could as well to try and increase our reach. So things like surveys, workshops, planning together, which is our quarterly partnership board. We offered one-to-one meetings, we visited services, day centres, schools, parent forums. We commissioned an expert by experience contract, so we enlisted their help with us, so they would go out to various services as well and engage on a peer-to-peer level, which was fantastic. And we basically fed that all together to then design the first kind of iteration of the specification. So if we go to the next slide, please. This is just this is an overview of kind of what people said and then what we did. So what we put in the specification in response to what people told us they wanted. So I'll just quickly go through these. So people said, we want providers to support people in services that are close together. As I said, originally the contracts were needs-based. In some instances, we had different providers delivering services on the same street, which didn't really make sense, to be honest. So we developed a locality model. So we'd have the locality model would be, so we had localities that were mapped against GP localities. So we have a north, central, west and south locality. And we asked for providers to deliver all the care and support in their locality, which really helped with things like rota management, time management, emergency support, and also that kind of knowledge of their local community, which in turn could be passed on to their service users to help connect them to the community. People said we want more choice and control. So our model was a Flexi model. And we've committed to phasing in individual service funds. So where people have their flexi element, they could have that as an individual service fund, so they have more choice and control about how they actually use those hours. It was a person-centered, strengths-based approach. We also created a contingency budget, which basically gave providers a little pool of budget where they could use it for emergency if they needed to flex support up. So there was kind of seamless provision without having to go through all this kind of approval process to get additional hours if needed in an emergency. People said we want to be part of the local community. So we put expectations around community asset mapping. We expect providers to become experts in their locality. We expected providers to develop their partnerships in the community, work across locality providers, and we also asked providers to commit to social value actions, which we then monitor them on throughout the contract. People said we want providers to invest in the service, so we offered a 10-year contract to give providers the stability and reassurance to really invest. We asked them to be strategic partners with us to draw off their expertise over the life of the contract, so it's a real partnership. We created a gain share mechanism together, which is essentially, it's like a mechanism where a portion of any efficiencies made after certain conditions are met, part of it will be given to the providers to reinvest into the service to kind of develop it and improve it even more. People said we want homes that are well maintained and in good repair. So we created a landlord charter, which is a set of kind of standards that we expect landlords to meet in terms of repairs and conditions. And the landlords signed up to that, and then we monitor them against that as well through contract monitoring. And then finally, people said we want better homes and more homes in Camden. So we created an accommodation strategy, which aims to improve and expand our stock. And we also changed the terms and conditions of our contract. So we've set it up so the locality providers, for most developments, would probably get first refusal of any new developments we make, and the terms and conditions have been changed, so it's really seamless for us to move services in and out of localities. So it's a much more seamless approach to it. Can we go on to the next slide, please? Thanks. So this is an overview of the tender process, and it's a total of about 4 months. It's quite a long procurement, and it was a competitive dialogue approach. And the competitive dialogue approach basically involves stages of dialogues, which we would have with bidders. And then we would have various discussions around elements of the specification. And then following dialogue, we would then update the specification and refine it. And we did that 2 stages of dialogue for that. So just to give you a bit of an overview about kind of the things we dialogued on. In our first round of dialogue, we discussed the locality model and around demand management, and then we revised the specification. In the second round of dialogue, we discussed things around the contingency budget, the key performance indicators. We talked about digital care systems. We talked about quality assurance and family care and service user feedback. And then again, we revised the specification. And after each time we revised the specification, bidders then had to submit a new bid, which we evaluated and then shortlisted to move on to the next stage. We also had a service user and carer presentation. So the panel basically created a video scenario, which they asked providers to respond to, and then the panel scored that, and that went into the final scores. So in terms of the approach we took here, we did a 60% quality and a 40% price split. So within that 60% quality, 10% was for social value and 8% was for the service user carer presentation. So following that, we were able to award to 3 providers to deliver across the 4 locality contracts. So we've got 1 provider who delivers across 2 locality contracts. If we can go on to the next slide, please. Okay, so we're about 1 year on now. So the contract started October last year. So I've just done a bit of a summary around kind of the key achievements so far. Mobilisation was through the height of the pandemic, so I think everyone did a fantastic job in keeping things going, and that was really successful. During the mobilisation period, we co-produced with the providers, with service users and family carers, various aspects of the contract. So we co-produced the key performance indicators, the referral pathway, our contract monitoring approach, and part of our contract monitoring approach is we've agreed for our expert by experience contract to regularly go into services to get direct feedback from service users independently, which you can feed into the monitoring process. In terms of outcomes, so it's a strengths-based approach. We are seeing improved independence, greater digital inclusion, development of new interests, hobbies, skills. We're starting to see some more examples of shared activities. We're seeing reduced hospital admissions and deaths, which I think is a real testament to the quality of provision. In terms of developments, so we've developed 1 new service already. We have another one that's going to be opening early next year, and we've got more further in the pipeline. Social value, which has been really good. So providers have kind of taken it upon themselves to set up a bit of a social value working group across the locality providers. So they come together independently to work in partnership to really deliver on the social commitments. So far they've done things like litter picking groups and events. They started looking at community mapping, and they've also started to create a series of apprenticeships for people with learning disabilities. And in terms of partnership working, I think that's been really strong. We have interlocality provider forums where they can share providers share best practice. We have accommodation planning group where providers and health and social care workers come together to plan accommodation and options and developments. And as I said, we've got that gain share mechanism as well. So we really work together to set targets and create efficiencies and really draw off each other's expertise. And then finally, in terms of evaluation, we've done a series of workshops and reflections, which we will be writing up, but generally the feedback has been really positive. People have felt listened to, people have felt heard, they felt like we've actually implemented what people have asked, which has been fantastic. In terms of providers, they felt really listened to. They've really invested into the process because it's quite a long procurement process. They've really invested into it. And I think the result of it is that actually we've got a really realistic and achievable specification delivered by providers who are truly invested. So that's been really good. So if we go into the last slide. Thanks. So we have time for some questions later, but I've just put my details here in case anyone wanted to kind of follow up and learn a bit more about it. But I will leave that there. So back to you, Liz.
Thanks very much, Poppy. It's really great to hear about the approach that's been taken in Camden, and just kind of picking up again on a couple of points that you shared that I think are really valuable in terms of reflecting on where we're at in terms of best practice commissioning. So within the approach that you took, the majority of people who are engaging that you engage with in terms of that planning together approach were people with learning disabilities. I think that's really, really important point about the work that you've been doing. You've pointed out the benefits of a locality model and approach, the need for a contingency budget for providers so that they can work flexibly and support that approach to working flexibly. There's a focus on quality in the tendering process, and that whole approach, what you're seeing is that that's led to reduced hospital admissions for people with learning disabilities, which is absolutely key, and that's all been achieved through strong partnership working. So thanks very much. I can see some questions coming through for Poppy already. If you do have any, please pop those in the chat. If we can't get to them today, we will post out answers after the webinar today. Brilliant. Okay, thanks, Poppy. Now it's next, I'm going to hand over to Candy, who's going to be talking to you about the commissioning for wellbeing qualification that you've been involved in. So over to you, Candy.
Hi, yeah. Yes, I'm really excited to have an opportunity today to talk through what some of my key learning was from this really fantastic qualification that I was able to be part of the pilot for. It is the BCSE Level 5 qualification in commissioning for wellbeing within a framework of learning disabilities and autism. You'll note when I talk about what it means to be a commissioner for wellbeing and that underpinning everything that we think about when we think about commissioning. And I just want to reflect a little bit on some of the speakers today and everything that people have talked about and the different hats that commissioners have had to wear in these different scenarios. So at the start, we had Nicola talking about how commissioners had been a really integral driving force to supporting good practice with the care and support and best outcomes for her son in terms of CQC and really reflecting on the importance of skilled, qualified and experienced commissioners being able to really lead some of the fantastic work that's happening across the country now. And if you think about how the role of a commissioner has really evolved over time, and I'm sure you can think of a number of different examples, if you know your history in terms of, maybe previously we would have been budget holders, we would have had a lot more sort of centralized control, and that's really changed. And this devolution of power in terms of what that looked like before and what that looks like today in terms of people being able to manage their own personal budgets, sort of looking more at micro commissioning, the emerging integrated care system and what that looks like for health and social care, and the changing roles of the VCSE sector and new and emerging contracting methods. There's so many different things that impact on our sector, and if anything, the sort of major public health emergency and COVID-19 and what we've all been working in over the last year and a half, it really has changed. And I really do feel that as all sort of attending this seminar on our laptops today, life is really different, and our approach to job satisfaction is actually really different, and trying to find a place in this new commissioning arena is quite difficult, but it's also incredibly meaningful, because I think if we can find a place to be a leader within all this change, and find a place to really be able to make system-wide differences to support people, then we're going to achieve that job satisfaction that's so important. So if I move to the next slide, I want to talk about what I was able to learn about commissioning, and how that's really helped me to be in some of those integral spaces that we've been hearing about throughout this webinar. So in this BCE level 5 qualification, so level 5 is sort of HND level. It's almost like doing a year of a university degree. Because I studied this during the COVID pandemic, it was all at home. It would generally have some classroom-based learning, but nothing too onerous. And there are 4 key learning outcomes, almost like modules, I just want to talk to you a little bit about. So it's the role of the Commissioner for Wellbeing, professional development for effective commissioning, the commissioning cycle, and commissioning together for outcomes. So I noted before that well-being is something that underpins every single thing that we should be doing, because it really should be based around the individual and about their independence and their ability to lead a full, meaningful life, to engage in full and meaningful activities that enrich their human experience. That's what we want to be at the heart of. And I think the first place that we start on this qualification is around professional development, and it asks us as commissioners to look into reflective practice and all the different mechanisms for that, so we can continually be reflecting on what it is that we've delivered today. You know, what impact did I make today? If I don't know if you're like me, but I absolutely hate getting out of bed. So every day when I go back to my bed, I want to think, what difference did I make today? What made it worth me getting up, me getting dressed, and me working in this sphere and doing everything that we have to do every day. So that's been really useful for me to be able to explore those mechanisms. I'm just seeing someone said, sorry, what's the qualification again? It's a BCSE level 5 commissioner qualification in commissioning for wellbeing. We also look at the commissioning cycle. I think it was really interesting hearing from Debbie just now about how you know, we really do need to be a qualified and experienced commissioner with a good understanding of what this is, so that we can tackle some of the challenges that are coming. And the commissioning cycle, it really shows us that commissioning is science. You know, it's sometimes referred to as an art, and what that looks like, and how we navigate that together. So I think I just want to very, very briefly touch on some of the things that come up in this qualification. And I think when we send out the slides, there'll be a resource that goes into a bit more detail about each element of this. So it's things like market shaping and workforce shaping. And I know a lot of that Poppy just touched on the fantastic work that she did for supported living, needing to understand what you've got, what does your market look like, and how is that impacting people's lives at the moment. Engagement and consultation and what that means, how you make it meaningful and how you utilize it at every single stage of the commissioning cycle. How we bring family and carers into that, and how we make sure that they're leading that rather than being passive or, you know, contributing and never hearing from us again, or you know, giving up their time and maybe spending money and being out of pocket for that, and never seeing any of the value that they're contributing. Utilizing community assets, which is really crucial, because we all know as commissioners, we don't come in with a big budget and we don't say, you know, here's how I'm going to make things different because I've got the money to do that. It's really understanding what your resources are today and how you can utilize them to create interventions and solutions. There's a lot about the viability of our interventions and how to understand exactly what it is that we're doing and the impact that's going to have in different areas. And, you know, is it going to work? And how are we going to assess for that? technology and innovation, because that's an integral driving force for our sector. How are we going to utilize that for care and support, and how do we make sure that that people still feel a sense of control and a sense of care, because we associate care with a sort of human interaction. So how do we bring technology into that? And there's some really fantastic ways that the course kind of asks you to explore that as a question for yourself. There's a lot around risk management, which we're faced with every single day. And it's really interesting to hear some of that in Debbie's presentation. It's a big thing for us about how do we positively look at the risk and create interventions that do explore positive risk taking, and to achieve better outcomes, and how do we mitigate for that. Partnerships is really integral across the system, and also procurement. What's the difference between commissioning and procurement? A lot of people don't understand that, and I'm sure many of us have been in those conversations where it's quite tricky to talk about what it is that we actually deliver, because we're so used to people assuming that just means buying a service, because maybe that's quite an outmoded model of what commissioning is, when we all know how often do we come in and say, let's buy a service? We can be doing so much more than that, and we can be working so much more creatively. So these are some of the really fantastic ways that, and there's so much more that I could go into, that this course asks you to look at your practice and look at how that you can be improving that. If I can go to the next slide, what I would like to talk about is how we put this learning into practice. So I told you before, I'm a commissioner for mental health and dementia, not learning disabilities. Oh, sorry, you asked me to have a little look at Jeanette's comment. Oh, I'm so sorry. I think I've given one organisation credit and not the other. I'll come back to that in just a second. So in terms of putting that learning into practice, I think it's all around how do we utilise that and how do we continually improve. So for me as a commissioner for mental health, something that I've recognised is we have this issue, and I think Nicola touched on it, about who's funding what, but also where do people fit, and what provide. I think Debbie was saying it as well. What providers can manage different types of interventions? If your primary if your primary need is LD, how can you be supported in terms of people's by a mental health provider or vice versa? And we know that many people with an LD may be more likely to get a cognitive disorder moving forward, like a dementia. So how do we make sure that our dementia services are able to support people with a learning disability, and how do we ensure those services are there? So a big part of my work now, in terms of bringing my experience of this qualification into practice, is working with LD commissioners to ensure that we're joining up the process. And a big thing that we're looking at now is housing. So we've got a number of people with autism, and the potential for them to fall down the cracks between mental health and learning disabilities is really quite astonishing. It's quite difficult to recognise how we're going to support people who fall into that cohort. So that's a big part of what I'm going to be doing to bring my learning into my practice. If I can just go on to the next slide. Yeah, so I came across this qualification via BCE Learn, but I think it's been picked up in the comments here that there are two providers delivering this. Of course, the pilot I was involved in was just with BCE. We're going to be sending around a number of different resources that will be able to let you know exactly where you can access this, as well as some new skills for care resources produced by NAS and NDTI for commissioning services for autistic adults. So yeah, that's me. Thanks very much.
Thanks very much, Candy. That's really helpful to get those insights and that overview about the qualification, what you feel the benefits of undertaking the qualification are. So kind of key messages there that I've picked up around what it means to be Commissioner for Wellbeing, what the role of the Commissioner is, that focus on continuous professional development and reflective practice, thinking really about the impact of commissioning on the individuals that we're supporting and what that means to and for people as well. So great. So if you've got questions for Candy, please do pop those in the chat, all the questions and answer box. And next we're going to come to Di. Di is Commissioning Development Lead, the Learning Disability and Autism Programme for NHS England, and she's going to be talking to us about the work of the commissioning team and particularly for people with learning disabilities and autism and the programme there. So over to you, Di.
Thank you very much, Liz, and I'll try to be relatively swift. I realise that we're running a little bit over time, but I think what I really wanted to let everybody know is just the range of support, guidance that we have in the NHS England Learning Disability and Autism Programme that's available to any commissioner really. So just a bit of background about us, that we're a relatively new team, so we were established in the midst of the pandemic really, but we are aligned and accountable to Building the Right Support Delivery Board, as well as the programme board in the Learning Disability and Autism Programme. And our job really is to support commissioners to enable them to commission creatively and for people's lives, not just a service. So you'll see there that I've just taken something from the National Service Model that was published alongside Building the Right Support. We try to provide that guidance and support for a whole range of commissioning, so strategic commissioning, operational commissioning, as well as some of that more individual and micro commissioning. And we actually cover quite a range of work, which I'll very briefly describe, but we've got things like commissioning capability. We cover personalisation and lived experience. We also pick up work around community capacity, working really closely with our colleagues in Skills for Care, Skills for Health, Learning and the LGA, Local Government Association. We also cover housing, and we run a capital housing programme, which I'll just talk about very briefly as we go on. We've also cover workforce as well as some of the commissioning oversight. And as I say, all of the guidance and details that we produce are available to anybody. They are on our website. And of course, you can come directly to us. Next slide, please. So it's probably just worth talking very, very briefly about our mission and values, really because we've tried to make the work that we do focus absolutely on human rights and around the fact that people are entitled to the same life as everybody else, or as a friend and colleague of mine says, a gloriously ordinary life built around the fact that people are citizens, whether they need any additional support or not, and that there are 7 things that you can see there that everybody should have as a citizen. Sometimes we all need a bit of help and support, but we're not defined by that. So we are saying that commissioning is about enabling the right to life, a life with purpose, relationships and aspirations, and about treating everyone with fairness and respect. Next slide, please. So again, this is just a little bit of work, and I will whiz through them. So you heard just before about the commissioning qualification. So we've worked really closely with Skills for Care, and we are funding places for NHS commissioners over a period of 3 years. So we're really trying to say, look, this is a great qualification, as you've just heard. So we're trying to make it possible for people to access that, working with Skills for Care, so that people who from the local government side of things are also involved in that. And one of the things that we've tried to do around the cohorts of students is make sure that we've got both NHS and local authority students, so that people can learn and develop with each other. Because one of the things that we know will happen as we move towards next April is around much more integration as the NHS moves into the sort of ICS world, so integrated commissioning systems. We publish quite a lot of commissioning resources, and I think Candy said before about the autism commissioning guidance that was published alongside the autism strategy. We're currently working on a learning disability one, as well as a number of other masterclasses, webinars, and other guidance. So we try to publish all of that on our website, but we can also publish that in other places as well. So it's well worth making sure that you're linked in with Skills for Care, because we work really closely with them. Next slide, please. So again, just a little bit to say about personalisation. People hopefully will have heard about universal personalised care. We link very closely with the personalised care group in NHS England, so that we can make sure that things like personal budgets, individual service funds, integrated budgets, as well as social prescribing and community-based support are really integrated and really linked together, because again, this is about having an ordinary life, and people with a learning disability and autistic people should have access to the same the same support and guidance that everybody else has. So we're working really, really closely with a range of people around personalisation. Next slide, please. It's worth mentioning a little bit about community capacity. So we're looking at working really closely with, or we have been with NDTI, the National Development Team for Inclusion, the Local Government Association, to help grow small person-centred organisations which can support people with, you'll see that we've put it in inverted commas, but hefty reputations in the community. We can provide you with some links to that work from the NDTI site. We've established quite a number of these areas. I think we've got 13 areas that are actually working together to try and develop some of these small supports. We also support peer reviews. So if areas want to learn from each other, we can bring those together through the LGA. And we've also undertaken a community mapping review so that we can understand where community services are. Next slide. Worth just saying a little bit about housing. I think earlier on people were saying, you know, that we want people to be living good lives in the community, and the most fundamental thing about being in the community is being at home and having your own home. So we have a national housing lead and then a number of regional housing leads who can help support with some of the guidance and intricacies of housing. We also run the NHS England Housing Capital Programme, where we can utilise NHS capital to purchase properties. So again, we've got a huge amount of support around that and a huge amount of guidance that we can provide, because it's about a true home, not a residential placement, that can provide security and stability. And again, we can send out more information, or people want to get in touch with me, we can provide more information on housing. Next slide, please. Worth mentioning just something about workforce, because clearly one of the things that's really important is having the right, as we've heard around supported living, it's about having the right workforce to support some of this work. So commissioners, we as commissioners, we do need to take account of the fact that we need to have the right people with the right values, behaviours and skills and capacity to deliver what we actually want to deliver. So we've got a national workforce lead around learning disability and autism, who's working to make sure that we've linked those things together. And again, we work really closely with the Local Government Association and other detail and other people as well. Next slide, please. And I think I'm coming up to the end of my slides. It's been a whistle-stop tour, but you will have these slides, and I'm really happy to answer any questions afterwards. But it's worth mentioning something about how we also provide guidance around oversight, because again, we heard how important it was to know what was happening, that commissioners can't just commission a place or a service or support and not know how that's going. So we've got a whole range of guidance around host commissioner arrangements, which is based around the locality of any inpatient units, and they have a mechanism for overseeing and coordinating local activity, working really closely with CQC. We've also got a structure of 6 to 8 week oversight visits, and supporting guidance was also introduced earlier this year. And you can see some of that detail there. And again, we've got quite a lot of guidance around that people can utilise. Next slide, and I think that might be my final slide. The next one. So we've got some work going on here around dynamic support registers. So this goes back to knowing your population. So as a commissioner, if you know your population, you know who's likely to need that support, it can make it a lot easier to try to plan what you might want to do. So you can just see here some work that's going on around the dynamic support registers and the dynamic support systems. And again, we have a national lead for the dynamic support work. Again, I can link people in if they've got any particular questions or queries. I'm thinking that might be my last slide, but if we move on, I will know. Yes, it is. I know that's a real whistle stop, but really happy to take any questions. I'm very happy to be contacted afterwards as well.
Oh, thanks very much, Di. It was a whistle stop, and apologies for that, but you managed to share a lot of information there in a very short space of time. People are asking for your email address in the chat, so if you can provide that would be fantastic. And honestly, it's great to hear about all the exciting and innovative work that's happening, that we're partnering with as part of our Homes Not Hospitals campaign as well in some areas, and that we're supporting, and that you know, commissioners can get involved in terms of all of that information, the wealth of information about the commissioning activity, the human rights-based approach, the National Housing Lead, the Dynamic Risk Register, all the work around housing capital. All of that information is there for commissioners and anyone else that's involved here to take a look at, and really, really important work again around the oversight arrangements as well. That again, that might be of help to lots of different people who are joining us today. So thank you very much indeed, Di. And if you've got any questions for Di, pop those in the chat as well. Okay. Great, thank you. Okay, so just before we go to questions from everyone in the audience today, I just want to kind of provide some key messages around our best practice commissioning work over at BASWA England in terms of our Homes Not Hospitals campaign. And it links to a lot of the work that's been shared today from colleagues, and particularly thinking about what those models and frameworks of best practice look like in terms of commissioning. And to do that, we very much looked at kind of policy development, guidance, research, looking at a sound evidence base, really, and really thinking about what we need to be focusing on in terms of people's journey and looking to take a lifespan approach. If we can have the next slide, please, that's great. So echoing the key messages that we've had from colleagues today, the importance of having a commissioning that's focused really on having that person-centered approach with co-produced local services. We know that too many people with learning disabilities and autistic people are stuck in hospitals due to delayed discharge, the inability to find the right housing, that's come through as a theme really strongly today, and the right support to enable people to be discharged in a timely way. It's been a recurring theme, certainly since Winterbourne View, and again, thinking about the experience that Nicola shared at the beginning of the webinar today about some of the issues and where things were getting stuck in terms of George's journey as well. So we're really focusing our campaign activity as well around the importance of social workers along with other health and social care professionals. Commissioners are included in that, in utilising the information that's out there, utilising the research, the commissioning qualification that we've heard about, nice guidance, the guidance that we've produced through our Homes Not Hospitals campaign, to ensure that we're working in a human rights-based way that's legally literate and evidence-based as well. The resources that have been created, along with those that have been shared through Skills for Care and Care Quality Commission today, there are links within all of that information that's there to strengthen and support practice at an individual and a systems level as well. If we can go to the next slide, please. So in terms of our campaigning activity, what we're really calling for is that national review of what's happening around commissioning arrangements up and down the country, to provide some accountability with the appointment of a national lead commissioner. The work that we've been doing brings together people and families with lived experience from across the sector and from across a number of different organisations, all of whom have been telling us really strongly, and again, this has come through today, that prevention is key. We need the right community-based support for families from childhood to prevent that pathway that can often lead to admission. And commissioning is an absolutely key element and aspect of that. The community support needs to be funded properly. We need to be developing support and services in a co-produced way with people with learning disabilities, with autistic people and their families. And what we need to be working towards is limited and only appropriate use of assessment treatment units. And that's not a replacement for where people should be living. We need homes, not hospitals. Next slide, please. In terms of the work that we've been doing, and again, if you want to get in touch, we'd love to hear from you. We've got a suite of documents and resources, again, that have been developed with social work, but also social care in mind, and really thinking about that best practice approach to commissioning. We've got endorsement from strategic partners in the room today and also in the wider sector. So please do take a look at those. All of our resources and those that have been talked about today are available as part of this slide pack, which will come to you after the webinar. We really want to come out and talk to you about this work. So please do feel free to invite myself along to any future meetings, or contact me if you want to find out more about the work that we've been doing, or get involved in our campaigning activity, which provides real opportunities for partnership working. Thank you very much for listening to me. And it's next slide, please. Okay. So it's time now to move to questions from the audience. And we've had quite a lot of stuff that's been coming in around the chat. Lots of focus on housing, and I'm going to just pick out some of the questions and who they might be targeted at, so just bear with me one moment. And just to say that any of the questions that we don't get to today, because we have got quite a lot, we will be looking to answer those after the webinar today, and we'll send that through on an email. We've got everybody's email addresses that's been registering for the webinar today, so we can do that. Poppy, there's quite a few questions that have come through for you in terms of the information that you've been sharing. And I'm just going to pick out a couple of those, if that's okay. So the first one I'm going to go to is, please, could you explain how the landlord charter works and what this entails? If you're able to do that in a succinct manner, or do you think that that's something that can be picked up after the webinar, Poppy?
Yeah, so I can provide some additional information after the webinar as well.
Brilliant.
Just very simply, then it's literally just kind of, so A4 piece of paper where we set our minimum standards. So things around how long repairs should take, how people should be contacted, what information should be provided to service users, and also commitments to landlords regularly visiting properties to check that they're in a good maintenance. And also commitments for landlords to work closer with commissioners to kind of report back on things and improving partnerships generally. So it's just kind of like a minimum standards, and we can use that to kind of monitor and work with our landlords. But I can share more information outside of this, if that will be helpful.
Yeah, that's fantastic, Poppy. And I can see some more questions popping up as you're kind of giving that explanation there, which is fantastic. We've had some questions that are coming through. Okay, around commissioning and knowledge base of commissioners as well. So there's comment there about accountability being essential with ongoing reviews, ensuring that housing and support continue to meet the needs of people following best practice. There's quite a few questions here. So I think this one, well, this is open to any of our speakers who might want to come in on this, around the scarcity of appropriate housing across the country. And how we can ensure that maybe specialists or particularly tailored support can be made available to people, particularly thinking about rural or underfunded areas. Di, I know that you touched on that in some of the work that NHS England have been doing around commissioning. I don't know whether you might want to come in on this, and then maybe we can take any of the speakers on that question.
Yeah, sure. And I'm really sorry, I've seemed to have lost my chat, so I can't see any of the questions that are coming in now. But yeah, one of the things that we found with regard to housing is really that housing tends to be left to the last minute. So one of the things that we're saying is that, bring housing in right at the very beginning, because sometimes, well, for anybody who's bought a house, it takes a long time. So the time factor really needs to be brought in there. And certainly for the capital programme, we can buy houses on the open market, and we can support commissioners in all sorts of ways around housing, but time's a real critical factor. So what I can do, and I did say that I would, I'll try and send around the regional housing leads, of which we've got 7, who can really support some of this, because again, as I say, it can be a timing issue. Not least because even in a rural area, if housing is scarce, our regional leads can help to think about what those solutions might be. But you know, again, it is a timing issue. But I can share a lot of the information that we've got that might help.
Thanks very much, Di. That's fantastic. Nicola, I want to come to you next. And quite early on in the chat, there were lots of thank yous. I don't know whether you might have spotted those in the chat for the, you know, for the fact that you've shared your story and George's story with us this morning. And in terms of particularly thinking about that aspect of commissioning that's made a real difference. I think one of the things that would be helpful to find out a bit more about is, what would you say the key things are in terms of that approach to commissioning, in terms of the commissioner's skills and knowledge that were particularly helpful in unlocking George's situation?
I think for us, they were very focused and they were prepared to listen to what I had to say and some of my experiences earlier on with George, and kind of going back to that baseline that I'd known about from when he was much younger and being part of the family and being involved in everything. And all the changes that had happened to him during his life since then. And yeah, they were prepared to listen to that and were very focused on finding the solutions. So, but also understanding the clinical point of view as well, and being very skilled negotiators in trying to bring everybody who was involved together and sharing the risk, because it is a huge risk. And like I'm used to George and I know what he's like, and I'm used to the risks, but yeah, it's being very focused on finding the solution and then going out there and getting things done and coming up with a solution that everybody was happy with.
Thanks very much, Nick. And you've picked up on a really, really important point there again about that risk, that sharing the risk. Certainly through the course of the work that we were doing in terms of developing the key documents around best practice commissioning, that was one of the messages that came through really, really strongly about the reason that things get stuck and that it's really difficult to find those innovative solutions or work in that kind of human rights-based way, really, is that where it's left to one organisation on their own to hold the situation. This is about everybody being involved, the right people being involved, with the right support at the right time. And going back to what Debbie was saying earlier about that culture and about there being the focus really on that this is everybody's business. If we're going to get situations to work for people well, and we're going to reduce the risk, we're going to reduce the need for very restrictive practices and isolation, then we've really all got to be willing to work together and to be there when things maybe don't work out in the way that we might have thought that they would, but be there to support each other as a team around the person and to keep trying and to try different things as well. So it's really helpful to hear that from you. Thank you. Great. Okay, thanks, Nicola. We've got another question here. How can we develop an integrated commissioning approach between clinical commissioning groups and local authorities? I'm not sure who might want to come in on that question at all. So how can we develop better working relationships and more joined up thinking in terms of commissioning approaches from local authorities and NHS clinical commissioning groups? Would anyone of the panel like to come in on that and offer their thoughts?
So I don't mind coming in on that, and I suppose my question would be, is that locally or nationally? Because I suppose locally the shift to integrated commissioning systems should make this a little bit easier locally. So obviously local authorities will be part of the integrated commissioning partnership. Even when CCGs cease to exist and become integrated commissioning boards, there will still need to be local authority representation there. So the whole focus of the new bill is around integration at a local level. At a national level, we already work really closely, as I said it earlier, with the local government association, as well as skills for care, as well as skills for health. So we're trying really hard to make sure that what we do is linked together, so that because then we're talking about commissioners in the round, because you actually can't differentiate in a lot of cases between, you know, what's NHS and what's local authority, because people just have one life. We should be supporting people to live their life. So I think that will be one of the things that will help, but clearly there's a lot to be worked through as we move towards that sort of integrated approach. So I think it is a bit of a watch this space, but I think you know, it's definitely moving in the right direction to make sure that people are linked at that level, at local level.
Thanks very much, Di. Yeah, and as you say, it's keeping an eye on the national kind of developments as well with the health and care bill, as you've said, which is kind of promoting far more around integration and looking at that. But we know that there are good examples of that happening across the country already. But also, it's about making sure that people can see how that integration has come about, what are the steps and what's worked well about that, I suppose, and you know, what have been the challenges along the way. Yeah, great, thank you very much. We've got a question here for Candy, I think. Candy, this is coming through the chat. What services are available for autistic people as they get older but may not fit into adult social care eligibility? Candy, is that something you feel able to answer at this stage?
Yeah, and I think there's obviously a national agenda to ensure that people with autism have their own place within that system. From my perspective, working within Somerset County Council, I don't think we got that balance quite right in terms of where autism fits. I think we're one of our strengths is one of our weaknesses, because we don't have a systematic approach where this is the approach every time. This is our commissioning strand. This is our designated commissioner who sits with autism. And I think that would be best practice, and that is something to develop toward. I think what we have instead is quite a creative approach to working with individuals with autism to ensure that we can meet their needs. That can sometimes be resource heavy because it hasn't always been so systematic. But I think what we do have in Somerset is some specialist providers who are fantastic at delivering tailored specialist support to people with autism, as well as specialist housing. We've got a couple of cases where we've had an opportunity as commissioners to be able to look at the resources that we have and then build things that are bespoke for some real complexities that sit with autism in terms of people who don't like, really struggle with sensory issues around sound. We've been able to soundproof apartments and things like that. But it is everybody kind of getting together to build towards, commissioners across learning disabilities and mental health and dementia working together on that. Whereas what would be good practice is specialist autism services delivered and championed by people with autism.
Mm-hmm. Yeah, so really what's needed is kind of almost going back to having a look at how can, if there are areas that haven't got any kind of specific services or aren't looking at that at the moment, is how that can be co-produced from the start with autistic people, so that there's that involvement in the design and then the delivery of those support services. And actually, through our best practice commissioning work, we identified that kind of model with North East Lincolnshire, and that's available as part of our practice resources to have a look at their approach and how that's working. And what that's been able to do is meaning that autistic people are very much the number of people who are on the board, in terms of autistic people, is a high number of people that they're involved in the decision making and in the design and delivery of services for autistic people, right through from that original diagnostic service, the assessment process, and then looking at what support is available for people within that area. So really good example there, and that fits with what you were saying there, Candy, as well. Thank you very much.
Can I
yes,
come in?
please do. Sorry, I can't see because I'm behind the chat. Yes, please do, Debbie.
I think one of the things we mustn't ever forget is that most autistic people will be using the same services as the rest of us. And whilst, yes, there is a need for some specialist services, I think there is more of a need that many of the services that we all use modify themselves a little to make sure that autistic people can access them well. So our acute hospitals, our GPs, our dentists, all of them need to really think about how do they make the adjustments that are needed to make sure that anyone can use their services, but particularly for autistic people when it may be quite difficult to go into those kind of settings. It's one of the things I'm struggling at the minute with the programme of work I'm doing, because I know that I'm not touching most of the people with autism who are using services because they are in mainstream services and therefore much more difficult to identify.
Thanks, Debbie. And that kind of brings us back, doesn't it, to the focus on human rights-based practice and reasonable adjustments within the Equality Act, and how organisations are or maybe aren't quite understanding the need for that approach at this stage. And certainly that links to what we've been talking about this morning in terms of the information that's available for people if people are not sure about maybe how to think about that, or what the right kind of questions they need to be asking themselves are. There's the information there from yourselves at the Care Quality Commission, and also through our partners here as well to help with that. So again, that's for the audience. Please do get in touch. We can help and support you with all of those elements. And that's really what this webinar is all about, is kind of demystifying, helping you to understand what information is out there so that we can have that best practice commissioning approach. Okay, I've just had a warning to say I think we've got time for one more comment and question. So I'm just going to have a quick look in the chat, and then I'm going to bring our webinar event to a close. And a huge thank you to everybody that's been contributing today in terms of panelists and people posing questions as well. I'm just having a quick look through here if we can just pull something out that's that we can get to here. Just bear with me 1 second. There's a question here which, again, any of our panel members can come to, but Nicola, this might be one for you to think about as well in your dual roles, family care, and also the role that you play in terms of your advocacy. So when family carers, the expert by experience, are recognised as important partners within this whole process, how can commissioners always make sure that family members are included? Thanks.
Yeah, sometimes it's about the family member needing support themselves, so they also might need an advocate. And I know I sometimes took a friend along just for the moral support, because some of the meetings that we go to as family members can be really overwhelming, and especially if you're in transition between children's and adult services. And I can remember one meeting that I went to while George was an inpatient for the first time. He was 16, 17. So we had children's social services and adult social services. And because I'd moved areas, we had 2 lots of everything. So there must have been about 30 people around the table. So I took somebody along with me just for that extra bit of moral support. And that really helped me to speak up. But most family members, I guess, would be really keen to be involved. And a lot of the parents that I speak to had say, oh, we weren't involved, or we were told we couldn't go, or there was a professionals meeting and we weren't invited. Just invite them. I'm sure they will turn up with or without support.
Thanks, Nicola. Di, did you want to come in just on that point?
Yeah, I was just going to agree. I think one of the difficulties is that we you know, as systems, we've developed this way of doing things, and actually we need to make it a lot easier for people to be involved. So, you know, don't ever just invite one person. It's really, 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 well, I'd find it incredibly scary, you know, being invited to something where everybody else seems to know the language and what's happening, and actually you're talking about somebody that I care about deeply. So as commissioners, I think we've really got to work on making sure that we're talking in human language, that we realise that we're talking about a person and about a person's life, and being really, really clear that the people that we're trying to support, they don't belong to us. They belong with the people who love them and who they love. And we really need to think that through a little bit more, because, you know, the people who know the person best are the people who we should be talking to them first. So I would say always think about how you can make it easier, and it should be easier in some ways now we're not tied to our desks almost, but I would absolutely say really think about how you can make things a bit more human and involve people.
Thanks, Di, and thank you, Nicola. And that absolutely, that approach applies to any professional, anyone that's working with people and families. It's our responsibility to make sure that people are supported to be involved, and that's a meaningful process for people as well. As Di was saying, we might only be involved for a short period of time, but this is about people and their lives, and how they can be supported to live good lives as well. So thank you very much to all of our panelists. Can I have the next slide, please? And to all of our audience as well, for taking part today. We really appreciate you joining and sticking with us. So we've had thanks for our Care Quality Commission colleagues, Skills for Care, NICE, NHS England, all of our speakers today, from Nicola sharing her and George's experience, from Deborah, from Poppy, from Candy, and Di, and myself. Thank you very much for joining us today. We've got 2 more webinars that are coming up in the series, so do take a look at the website if you'd like to book on. Really important that we get your feedback as well from today, and links to future events will be shared with you along with the resources that we've been talking about today after the event. So a huge thank you to all involved, and we hope to see you again. Thank you very much.